Hello.
Hi, how are you?
Well, how are you today, Jessica?
I'm doing okay.
Okay, so I need to give everyone a few minutes to join, but I do have a moderator checklist for us to go over. Not too intensive, just want to make sure everything's working correctly and that everyone has updated their name. So that'll be the first thing we do. Just updating our names. If my computer works. So welcome. Please note that this session is being recorded. If you do not consent to being recorded, we are going to ask that you please drop off of the session at this time. Thank you. Welcome and thank you for attending this Institute of the National Tribal Public Health Summit. My name is Jessica Dean. I am a project coordinator with the National Indian Health Board. Today I have the honor of moderating your session and also participating as a co-presenter for today's Institute. Today we are grateful to have President Terry Parton from the Wichita and affiliated tribes, Dr. April Cross from the Pasco-Yaqui tribe, and Jessica Constant from the Public Health Accreditation Board. They will be presenting on tools for building tribal public health capacity. This session will run from 12 to 2 p.m. Eastern Time. Please be aware that this session is being recorded. All participants have been muted. Please leave yourself on mute until the question and answer portions at the midpoint and end of this session. You may also type your questions and comments into the chat box here in the Zoom room, and the presenters will take time to answer your questions during their Q&A portions. I would also like to bring to your attention several features for our conference website. On the page for the session, you will find today's slides, which will be uploaded after our presentation. These will be available to download from the Files tab. There is also a chat box on the session page, and this is where attendees and presenters can continue any conversations after our time here today. Finally, please take a few seconds after today's workshop to fill out the evaluation. You can find the link that says, please fill out this session evaluation on the same page in the online conference agenda, which will be under the session description. Now, I am pleased to introduce our speakers for today's Institute. First, we have Terry Parton, who currently serves as the president of the Wichita and affiliated tribes. She is an enrolled member of the Wichita and affiliated tribes. She has a bachelor's degree in business administration and a master of jurisprudence in Indian law. She has worked for the Wichita and affiliated tribes for 23 and a half years, beginning her service to the tribe in January 1998. President Parton has worked in several capacities for her tribe throughout the years, including serving as tribal government services specialist, where she performed work in the enrollment office, tag office, bureau assistance, children clothing assistance, elder payments, National Park Service, and grants, as well as other capacities. President Parton has also written several grants on behalf of her tribe and has taught Wichita language classes for 3 years. President Parton is the first elected woman president for the Wichita and affiliated tribes, and she was elected as the president for the Wichita and affiliated tribes in July 2012, serving for 4 years, and was re-elected in July 2016, and most recently re-elected in July 2020 for another 4-year term. Dr. April Cross is the director of the Pasco-Yaqui Tribe Dolores Flores Healing Center and practices medicine there as a naturopathic doctor. She is also the accreditation coordinator for the Pasco-Yaqui Tribe Health Department and helped to become accredited in August 2021. Before coming to Pasco-Yaqui Tribe, she worked as a primary care practitioner in various offices in Metro Phoenix, Arizona. She has extensive experience working in integrative medicine and enjoys working in multidisciplinary clinics. Jessica Cronston is the Vice President for Program, Research, and Evaluation at the Public Health Accreditation Board, also known as PHAB. In that role, she oversees the administration and evaluation of the National Accreditation Program for state, local, tribal, and territorial health departments, as well as efforts to build the evidence base around accreditation requirements and public health practice. She also engages in research and evaluation activities for the Public Health National Center for Innovations, a division of PHAB. Prior to coming to PHAB, she worked at NORC at the University of Chicago in the Public Health Foundation. Welcome, everyone. So I will begin our presentation today. I'm sharing our screen. Okay. So today, once again, we'll be covering tools for building tribal public health capacity. If this is your first time attending an NIHB presentation, we do like to provide a little bit of background information about our organization. So the National Indian Health Board, also known as NIHB, is a 501c3 charitable organization created by the tribe over 40 years ago to advocate for improved health for American Indian and Alaska Natives. NIHB is the only national organization of its kind, serving all federally recognized tribes and advocating on all issues related to health, as well as public health in Indian country. NIHB provides policy analysis, as well as real-time communications to tribes throughout Indian country in partnership with its members, the area Indian health boards, as well as in places where no health boards exist with tribes in the region. In the first part of today's institute, we want to examine public health infrastructure, the structure and networks that are needed to support capacity needed to provide public health services in tribal communities. We'll take a moment to engage with you on brainstorming, discussing what parts of capacity and infrastructure are important or might be missing from non-tribal definitions, as well as parts that could be emphasized for tribes. We'll explore more areas that require tribal public health capacities to support efficient services and hear from the Public Health Accreditation Board as they present some of the vital resources and tools, as well as updates for their standards and measures. We will wrap up by taking a closer look at the services provided by public health systems, and again, which pieces are relevant to tribal public health systems through the lens of 2 tribal public health departments. So before we begin, just to provide kind of like a background or foundational overview, we do want to begin by drawing the difference between public health and healthcare, with an emphasis that we are specifically focusing on measuring public health, which is often considered population health. So population health is what protects and promotes health in communities in comparison to healthcare, which is going to focus more on the treatment of an individual for disease and or injury. So not only that, but we ideally like to think of this approach as a shift between preventative practice instead of operating in result of illness or disease, which has already been present or occurred. So we found that there is no set definition specifically for tribal public health, and recognize that tribal nations have an inherent right to promote and protect the health and welfare of their citizens using methods most relevant for their communities. So along with the management, that means that the priorities, your services, even traditions and cultures of each tribe may vary, and ultimately it's up to each tribe to determine what public health looks like for them. So the term public health capacity describes the ability to perform work related to public health practice. There is no widely used definition for this dynamic as well, but that includes the spelling out of elements or common themes that are unique in Indian country. So we refer to tribal public health capacity in the same perspective of the ability to perform work related to public health services and for Indian country. So This process of developing public health capacity includes strengthening knowledge bases, systems, and also your leadership. And through these efforts, providing opportunities for tribal public health departments to plan for both short and long-term public health operations. So these efforts include the work and collaboration of many groups and individuals. So considering what the infrastructure of tribal public health looks like, this diagram basically shows the relationship of what an example tribal public health agency or institution or system in a community will look like. So any system is simply a collection of your interrelated pieces, the people, also your organizations, and how they're connected and working together. So public health is very complex. It's made up of multiple entities, systems, and everyone has a different role in helping everything run efficiently. So you may see some familiar departments or teams that align with systems within your own community, and there may be some that are missing. The lines are going to represent your partnerships, your connections, but what we can't really see through this diagram is exactly what each member contributes. It's important to note that some of the connections may be stronger than there are others that support activities on a more active basis than others, but each component is going to be important. And then during our current environment with COVID, this is a really good example of a health issue that affects every institution or system within your community. So you can think about all the different entities that have to be connected for response efforts, and even those that may not have been as active before, but are now at the forefront. So if the connections are not as strong or perhaps non-existent, it could very well be hard to work together or work efficiently. So I would imagine that for all of us, there are partners or relationships that you may not have had before, or those relationships that have become stronger or even changed in ways as we take on more responsibilities to balance our new workflows as well as our priorities. So overall, when thinking about capacity, we're thinking about the ability of tribes and all those interconnected people, organizations, as well as their knowledge, skill, and support to carry out not just your services, but efficient public health services together and support a strong public health infrastructure, which we know to be kind of our framework to how those systems function. All right, so we also want to distinguish between community infrastructure as well as built infrastructure and public health infrastructure, and point out that community infrastructure does impact population health, but the pieces themselves don't produce health, so they're considered neutral. So for example, transportation doesn't produce health. The quality of transportation, the safety of it, where it's located, as well as components like where it goes and when it operates can impact health. Same as with broadband, which is really coming into the forefront with services such as telehealth, but broadband itself is going to be considered neutral. So just because you have broadband doesn't mean people will automatically be healthy. It's how you use it, such as for telehealth, and getting people access to care and factors such as who can afford it or who has capacity to get connected. Okay, so before we move forward, I do want to take a moment to get everyone engaged. So our session isn't just sitting behind the computer screen and listening for the day. So I want to ask everyone to brainstorm with us. And our first activity is going to be to jot down 3 things, 1 or 2 words each, that you think of when you consider what is needed for tribes to provide efficient public health services, or essentially promote and protect public health within your community. So you can participate in this activity by commenting in the chat box. However, let's see. We're going to make it a little bit challenging since funding and workforce are pretty much the two things that are most commonly expressed. We could do a lot of things with funding. So we're going to make it a little bit challenging to ask that you not include funding as well as workforce. So what other things can you think of that come to mind to help you to promote those services? Let's see. Let me get our chat box open so we can see what everyone says. Thank you, Lily. Lily came in first with communication, policy, and partnership. Great examples. Codes and ordinances, support and understanding from tribal leadership, access to safe water, access to safe roads or other alternative transportation, systems and collected data. Oops, coming kind of fast. Policy and procedures, state partnerships, county level recognition, system to collect and track data. Leadership support, very essential. Access to cultural practices, inclusion of in traditional medicine, definitely. Policies that protect and support staff. Key stakeholders. Okay, you guys are on it. These are really great responses. Mentor-mentee programs such as public health infrastructures. Definitely something that's coming up as we really consider the pipeline to tribal public health professionals. It's a great one. Policy updates, more homes and rehabilitation centers. Okay, awesome. Trust, community engagement, prevention emphasis. Okay, so you guys are on it. Really great responses, all applicable. I do want to thank you for participating. Again, I do want to mention that public health is very complex, so there really is no right or wrong answer to that question. And once again, there really isn't a hard or fast definition for tribal public health infrastructure. So it's broad, it changes over time, depending on your population health needs and your health. So even just thinking 30 years ago, when we talked about broadband as an example, likely it wouldn't be used the same way it's used today 30 years ago. So you can see how things are evolving. Okay. Okay, so when we're working to develop tools and resources that speak to public health infrastructure needs, we really look to tribes to tell us where they need support and what's going on in the field. So these are just a few places that we have identified where tribal voices are being heard. And we also work diligently to ensure adequate inclusion among our national partners so that tribes can contribute to our national frameworks and those tools in public health that are being released. And then once again, at the bottom, there's a where else statement, because this list may not be best fit for every setting or situation. So we're always open to learning what's new or what we may not be aware of or what's just coming about. So always ears to the ground so that we can assess and adapt to what's coming forth. All right, so here we have some of the infrastructure components that have been identified through our work with tribes. So this includes authority, administration, public engagement, partnerships, workforce, information systems, as well as funding. So these are some of the areas that you want to support through capacity building in order to ensure that you are able to provide efficient public health services. But there may be areas as well amongst those components that we're not aware of or that are just emerging once again. So once again, you see those question marks at the bottom where you can contribute additional areas of or components for infrastructure. So once again, getting everyone engaged. We want to take things a step further And one thing that was brought up a few minutes ago by someone, I'm not particularly sure who it was, but culture and the inclusion of culture in our practices was brought up. So we want to see where you think culture fits into these components. So you can participate once again by using the chat box. We also have our annotate feature, which is really fun. If you go to the top of your screen, you can use the little drop box to select the icon. And we're just going to ask that you place an icon next to whatever component you think that culture should fit in. Let's see. Our chat box open again. Okay, so I'm seeing some stars popping up around partnerships, engagement, administration, authority. Lots around authority, workforce, information systems, funding streams. And then if you have any ideas of things that should be considered for infrastructure or capacity components, you can type those in using the annotate feature as well, and just place those next to those question marks at the bottom. Let's see what we have in the chat box. So Lizzie Moore says, I think culture fits in everywhere. Don't think you should isolate to one place over the other. President Parton agrees, culture needs to take place in all areas. And Ashley Mitchell adds authority and information systems. Okay. Okay, Shauna Murphy says membership with state or local healthcare coalitions. So that could fall under your partnerships. Okay. So yeah, so we're seeing culture being emphasized amongst all of these components. And then Brandon has a comment. It says, it depends on which culture we are applying. Some tribal nations would prefer a robust hands-on approach. That's very true. Once again, it would depend on your priorities or your preferences that you find amongst your community and your tribe. Okay, thank you, everyone. Let's get our screen cleared. There we go. So we also want to note that the efforts to promote policies, your systems, as well as the services that promote those noted components, those can be linked back to the Tennessee Central Service of Public Health, which we know can be used to strengthen them. So while we won't deep dive into each of those services during today's institute due to, just the constraint of time, we do want to mention that these services describe the activities that communities should basically undertake to promote public health, and which you should focus on, and with the adaptations for the current public health environment and the revision of our tools, equity has now been put as a core value for this structure, for this framework as well. So thinking about that, we also consider that the Tennessee Central Services are a central tool for our first tool that we'll hear about today, which is going to be tribal public health capacity supported through voluntary public health accreditation. So this framework is supported through the Public Health Accreditation Board, which is linked to which links to demonstrating capacity by carrying out the Tennessee Central Services and uses accreditation basically to examine your operations, your systems, staffing, your functions, and even your outcomes for your public health efforts. And this is done against a set of national standards. So in alignment to. So today, There we go. So today I would like to turn it over to Jessica Constant, who's joining us from the Public Health Accreditation Board, so that we can hear about her wonderful services that she provides, all their awesome updates and revisions that they have taken place.
So thank you so much, Jessica, and really what a perfect transition to what we're going to talk about today. So first I want to just, I'm not Marita Chilton. I am stepping in for her, and I also want to say she's very sorry that she can't be here today. She had family emergency, and also unfortunately, because we had to do this last minute switch, I'm going to have to jump out after my session, so I won't be able to join you for the full 2 hours, but I've really enjoyed the discussion thus far, and I'm really looking forward to sharing some updates with you all, and hope to have some questions and discussion generated from that. So to get started, if you'll go to the next slide, Jessica. What accreditation, as we said, really fits in nicely to that conversation that we were just having, because it is about, you know, I feel like I'm repeating the last slide, but it is about those standards. And really what the standards can be is almost a roadmap of what does it look like to be able to deliver those essential public health services. What are some of the specific steps when you want to sort of take those big concepts that are in the essential public health services and think about what they look like in a particular health department? That's what the standards are meant to do. And the accreditation process also allows for that, not only that self-assessment of how well do we meet those standards, what new policies are we going to put in place, how are we going to continue to improve our operations to meet those standards, but there's also a component where peers are helping to provide feedback and identify those areas where health departments are really strong and where additional work can be made in those areas that relate to public health capacity. I really like this quote here on the left that talks about, even, it's from a very small tribe and how they really benefited from this notion of improvement, being something, quality improvement being something that they realize they can embrace and they can do and can continue to make changes to improve the way they operate and the way they serve their community. So next slide, please. In addition, today I'm really going to be focusing most of the conversation about accreditation, but I did want to just point out a couple of additional services that are available from FAB. Jessica, I don't know if there's a lag. I'm still seeing. Perfect. Thank you. So in addition to accreditation, we do have some other things that are offered throughout FAB that might be valuable. I don't know, are folks familiar with this diagram on the left? This is the Foundational Public Health Services. It's another framework that can be used to describe the role of health departments. And the way it is laid out on the top, you have some of those program areas that ought to be available for all individuals wherever they reside, so they have access to those. But then I think most germane to our conversation today, that model identifies 8 foundational capabilities, which really get to those same capacity questions. A lot of the things that you all were putting in the chat before about, partnerships being important, the data piece, policies, some of the other things are lumped together under organizational competencies, but you'd see there some of the things that also came up in terms of, budgeting and human resources and working on that pipeline for new employees. This model sort of is another way of encapsulating sort of what are those underlying capabilities that are needed to support public health services in any community. And so FAB can also help with doing assessments against this model as well, the Foundational Public Health Services model, in addition to the types of, the items that are in the standards and measures. We have a learning collaborative, which has now about 19 or 20 states that are involved, or talking about really, it's about systems level approaches. And so a lot of those systems incorporate, how can we, from the state, the local, the tribal health department level, how can we come together and think about what's the best way to deliver public health so that the services are available throughout the community. So that's another opportunity if you all are collaborating with states that have that are participating in that, that's another way to be engaged with other public health practitioners across the country to really think through what are the best ways to advance practice and to transform systems. And then today we'll really focus on these last 2 bullets about the Pathways program and accreditation. So next slide, please. This next slide here sort of shows this is really getting to that contextual piece. And so I'd love, as I'm talking through this slide and the next slide, if you want to add into the chat some of the challenges that we're really facing now. This is something that as we were working on version 2022, which is the revision of those standards and measures for the accreditation program, we were really mindful of some of the current challenges. So if you wanted to, I would welcome you to throw into chat what you think are some of the issues that have really come to the forefront in the last couple of years. It turned out, fortunately for us, that this is when we were revising the standards and measures, and so we were able to take into account some of those new challenges and emerging issues. So obviously with COVID, it drew a focus on emergency preparedness and infectious disease. There's been a very large focus on equity and racism as a public health emergency. The need for data have become really clear. Having access to informatics and technology. Also, communication has become another theme. So those are some of the themes you can see in that bottom left corner, some of the major themes we've identified. But as I said, I would welcome anyone to add to chat if you have other themes that you would want to nominate for some of the challenges or some of the main issues that are in public health practice today. And we hope that this new version of the standards and measures is really designed to be able to address some of those issues. So as I said, if you think we missed any big ones or little ones, anything you think we've missed, please feel free to put those in chat. You'll go to the next slide. I just want to take a minute to talk through the process of where we got to for version 2022. And really the important piece there is it was a very long process. We spent several years on it. But the important thread throughout is getting feedback from the field. And in particular, we're very appreciative of the feedback that we received from many tribal health departments throughout this process. We had a series of think tanks, which were sessions where we could listen to public health practitioners discuss various issues. So we had some topical ones, so about quality improvement, about communication science, about law. We also convened with the support of NIHB and a special set of sessions with a tribal work group to help think through, are there any particular connotations of these that we should be considering as we work on the revision. We also had previously, many of you are aware that we had previously developed a tribal supplement to the prior version of the standards and measures. So we're really mindful of that information, and we saw it based on the recommendations from the tribal work group. We saw how can we incorporate that guidelines into the standards and measures themselves. And then we had a very extensive vetting session, which we made available for any member of the public. We had a special extended session for those tribal health departments that are going through the accreditation process. And NIHB hosted a listening session for those health departments who could consider what was in the standards and measures and provide additional feedback. And all of that work over those years resulted in the new version of the standards and measures. So if you go to the next slide, I want to share some of the feedback that we received from the tribal work group. So here are the themes that we heard. This is when the tribal work group made some recommendations to FAB back in 2020. So some of the things we heard is we should streamline the standards and measures and focus on meeting the intent of the measure as opposed to providing documentation. There's a recommendation that we consolidate requirements into one section to make it easier to read and understand, that we provide more guidance and examples, that we keep in mind small and rural health departments, that we are mindful about language about sovereignty and including that within the standards and measures where appropriate, and that we also really think through the definition of jurisdiction and community. So I'm going to, in the next several slides, show you some of the things that we've done with the standards and measures and how this really is responsive, we think, to the feedback that we heard from you all and from others. So on the next slide, you can see some of the sort of the key takeaways, and I'll go into more detail about some of these as we go forward. So some of the big changes for those of you who are interested in seeing the new version of the standards and measures, we really did, as I say, take into account some of those pieces that came from the lessons that we're learning every day. So one of them, as I said, is we really incorporated equity throughout. We really focused on, realigning the preparedness and response recommendations with some other national standards so that they were close, more similar to what health departments experience when they in other parts of the emergency preparedness realm. We really look to clarify and simplify, so to remove redundancies, to really focus, again, to that point about how can we meet the intent of the measure. So let's see if there are multiple ways and there are easier ways to show that you've done something. Let's do that, as opposed to being very prescriptive about how you need to show that you have met a particular measure. And then we also focused on those foundational capabilities to promote accountability. So in that diagram that I showed earlier, there were those 8 boxes on the bottom, which were the foundational capabilities. And we really wanted to make clear in the measures how those capability measures play out, in particular requirements for accreditation, so that if you are looking for how to build capacity for your health department and you're using that framework, you can see how that fits together. And thank you. I'm seeing some comments in the chat about some of the challenges that came to light here, and we definitely hear you. And I think you'll see we tried to really address some of those things, particularly about data sovereignty, as we were going through some of these measures and what that relationship is between the requirements for and how things play out during emergencies, and what the relationships among various different entities within emergencies. And we really reframed how some of that works to try to address some of the challenges that I think we all observed over the last several years. So with the next slide, why not talk a little bit about where equity came into version 2022. And I think this follows on nicely with the contributions that you all made when you were talking about where culture plays into capacity. And I think we took a similar stance that it really falls in throughout all of the capacity, all the components within the accreditation across the 10 domains. And so here are a couple of examples of places, and these are not the full list, just a few examples of where we've really made more explicit the need to be mindful about culture, to be mindful about how different policies may play out amongst different populations and subpopulations. And so it's everything from, in our domain 2, when we're looking at how, when you're trying to contain or mitigate a public health problem, how are you being mindful of what the potential implications are for different populations? To in communication, so that second box in our domain 3 measure, about making sure that communications really strive to demonstrate cultural humility. And on throughout them, we, important through workforce in domain 8. So we really, are showing through this slide just a few of those examples of where we are really emphasizing this throughout the requirements. Next slide. Yes, thank you. I'm seeing in there the need to focus on those historical determinants of health. And you'll see within the standards and measures themselves, we've really made that much more clear about the role of history and those populations that have historically been marginalized, or where policies have in the past, created these inequities or continue to create those imbalances. We really want to call that to attention and really see health departments as playing a key role in paying attention to those factors. So this next slide goes from the real content of it to the practicalities. And I think this is good news for health departments who are considering accreditation. Part of what we did is really streamline the requirements. So we found that there was a lot of redundancy that we could remove. So it used to be there were 3 different measures that all asked for similar things related to reviewing policies and laws. And we agree, just as you all pointed out, policy codes play a key role in public health capacity. But that said, we didn't need to have 3 measures asking the same question. We were able to consolidate with just one. So the bottom line, if you look at the blue boxes towards the rear of this slide, you'll see that for initial accreditation, there are about 90 fewer documents are required in the new version, because we were able to sort of get rid of those places where we were asking for either documentation we didn't really need, or documentation was being asked for in multiple places. Next slide. This next slide also will probably be most meaningful for those who are familiar with the current accreditation standards and measures, and who might see this as more of a difference in the new measure. But one of the recommendations from before was just being very, very clear about what is required. So we actually really changed the layout of the standards and measures to be very explicit that everything in that dark gray column to the left, those are all the pieces that need to be required. And then we added additional examples in the right to try to show what do we mean by that. You'll see in this slide, there are all these things in parentheses that are EGs. So these are just examples. These are not things you'd have to use to be able to demonstrate conformity, but just ways to sort of trigger some thinking about what might be a potential way of demonstrating conformity with the requirements. Next slide. One of the other things, and here's where I think the feedback that we received from NIHB and our tribal partners was particularly helpful, was in rethinking some of the requirements that we had that were for state health departments. So it used to be in the current version of the standards and measures, there are a couple of places where the state is required to provide technical assistance to local and tribal health departments. And the way we've reframed it now is that the state needs to understand what tribal and local health departments' needs might be, and then provide support that is responsive to those needs. And so that's a pretty big reframing, and we think we really hope will help to foster more productive relationships between state health departments and tribal and local health departments. We also made it really clear that communication and coordination of services is key and needs to be in recognition of tribal sovereignty. So in particular, and this came up in one of the comments in the chat earlier about the need to be clear about different lines of authority and things like that, particularly in preparedness instances. And so we tried to add that context into the standards and measures. Next slide, please. Thank you. One of the other pieces of feedback we received is being really clear about what is a community. And I think that I'm seeing in the corner of my eye some conversation in chat about being able to understand to some extent what we're talking about in terms of where the community is. And so we added some clarification that for things like the community health assessment or the community health improvement plan, it is truly up to the tribal health department to determine which community they are serving here. So is it all enrolled members? Is it enrolled members living within a jurisdictional area? Is it everybody who lives within a jurisdictional area? So lots of different options, and we really think that it's important for the tribal health department to be able to make that assessment themselves and to determine what that area is. Next slide, please. And then a piece of data sovereignty we also wanted to be really clear about as well. And so we reference in several different measures. So here you can see in the third paragraph on the guidance one, some language that it really is up to the tribal health department to whom the community health assessment should be shared. We make that point elsewhere. So for example, when we have requirements about what needs to be on the website, we realize that tribes have to make the decision for themselves about what kind of data they would want to share on their website, for example. So that was another direct response to some of the comments that we received from the tribal work group. Next slide. So finally, I want to go back to this point that we raised earlier about those foundational capabilities measures. And as I said, we designated 34 measures that address foundational capabilities within the standards and measures. They don't necessarily meet every single sentence, match perfectly the way it is spelled out in the foundational capabilities, but we really wanted to match that spirit. And that, again, the idea is to make sure that health departments who are meeting the standards and measures are being able to demonstrate that those capabilities are available. Next slide. And this really plays an important role into our new Pathways Performance Recognition Program. So here's another effort that we've done. We've had multiple conversations with NIHB, with the Tribal Advisory Group and others to develop a program that is meant to support performance improvement, but be sort of a milestone for health departments that are not yet ready for accreditation. So the idea is for those health departments who look at the accreditation standards and measures and feel like it's a little bit too much to try to grapple with all at once, an opportunity to be able to work on it in smaller chunks and to be able to build capacity in a more stepwise fashion as opposed to attempting the full standards and measures in one go. So it really is, meant as a tool to sort of prepare for accreditation. It is not accreditation itself, it is a recognition, but to really help those health departments on their journey. I will say we're still finalizing the details, but we do expect to launch this program in this summer. And the next slide shows a little bit more details about this program. So basically, as I mentioned, we identified 34 foundational capabilities measures. We've divided those into 2 tracks. So the first track corresponds with the first 7 domains, or with these 5 capabilities related to assessment, preparedness, communications, policy, and partnerships. And then the second track is focusing on organizational competencies and accountability and performance management. So a health department can choose to just focus on one track, period, just do one track. They can do both tracks at the same time. They can do one track and then the other track. But as I said, it's meant to be a way of really focusing on a subset of those national standards as opposed to going through the entire process at once. The process is similar to accreditation in that health departments would read the standards and measures. It's the same standards and measures, just a smaller subset of them, provide documentation, and then be assessed on that documentation. There would also be some incentives so that if you go through accreditation and you apply, or if you go through pathways and apply for accreditation within a period of time, some of the work that you've done will carry forward directly. And finally, there's a learning community component to this program to really help support peer learning as health departments are going through this effort. Next slide. The final thing I want to talk about accreditation is that we have also simplified and reduced the fees. So for those of you who are familiar with our old fee schedule, it used to be that health departments had to pay a one-time fee when they first applied, and then they would pay an annual fee each year afterwards. We have gotten rid of that first year fee. So it used to be anywhere between $14,000 and $56,000, and that has gone away. So this really does significantly reduce the fees for accreditation. The one thing we've added is a much smaller fee, which is for readiness and a readiness assessment and some training. So in order to be able to provide training earlier on before you submit your full application for accreditation, we do have this, this smaller fee first that gives you access to training, as well as a readiness assessment tool, which will really help health departments determine where they are in terms of, it's really that first step in doing a self-assessment, a really detailed self-assessment against the standards and measures, and then getting some feedback from FAB staff about potential readiness to be able to either apply for pathways or for accreditation. And as you'll see here, even though there's the fee for that is $1,300, if you do apply for accreditation within 1 year, you are able to apply $500 of that as a credit towards the accreditation fee. So we hope this will really help health departments kind of know when they're ready and be able to approach accreditation from that standpoint. On the next slide, you'll see a couple of resources that are available. So if you are interested in either accreditation or in pathways, you can take a look at where our standards and measures are. We have, a frequently asked questions document. We have some of the things that I've shown you on this screen, brief shots about the equity measures. We also have some other webinars. So there's a lot of resources that are available on the website now. And finally, before I wrap things up, we also do have our Learning Center, which has trainings specific to accreditation and reaccreditation. There's trainings for a new accreditation coordinator. We have a course that really looks at how quality improvement has been used and has been applied for COVID-19 response. And we also have a new series that really talks about how health departments have maneuvered through the response and have used the accreditation standards as a tool for that. So with that, I'd really like to open it up for any questions or comments.
Okay, thank you so much, Jessica. We're going to open the floor for comments. You can participate 2 ways. You can unmute your line and share your feedback or comments, and then you can also leave your comments or questions within our chat box for the room. Let's see.
I know there are a couple of questions that came in, a couple of comments, questions from Lizzie Moore, so thank you for raising those questions. I think there are a couple of different questions that you pose. One, that equity is both about within a tribe and then from outside of tribe between tribal communities and elsewhere. And we do agree, and we encourage health departments, tribal health departments, to think about both. Where might there be differences within populations within the tribal community as well? So thank you for raising that. And the last question I really think is a great question to open up for others about what are the best practices for ensuring equitable approaches. So I would love to open that up for discussion or for further comments in the chat.
I'm going to stop sharing our screen for just a second so we can see anyone that would like to share.
Yeah, thank you. There's another, while you're thinking about this, Lizzie posed such a good, challenging question. So while we're all contemplating that, I see Katie asked a question about a way for those who are already accredited to go from 12 domains to 10. So we do have a couple of resources on our webpage. We do have a crosswalk that kind of shows you if you're familiar with the old version of the standards and measures, and here are the new ones, it kind of tells you where the big picture changes are. So that's a good tool. And we've also talked it through. We have a recording now, and we're going to be developing new trainings that kind of talk you through on a high level what's the content of each domain. So it can kind of show you what happened in that shift. The big shift is that the new Essential Public Health Services framework, which Jessica shared earlier, incorporates governance and administration and management into the 10th Essential Public Health Service. And so we made that same shift. So those things that used to be in domains 11 and 12, now we're able to shift into 10. And then what used to be domain 10 is now combined into domain 9. So that's the biggest change, but we do have a crosswalk that kind of walks through some of the specifics. Are there other questions? Well, I want to thank you all for listening. As I said at the beginning, I do apologize, but I am going to need to run. But if there are any other questions, please feel free to reach out to me. If there are questions that come up here, Jessica will pass them on to me. And I'm also going to just put in the chat my email address, so you can always feel free to email me directly afterwards. But thank you so much.
Yes, and thank you, Jessica. We're so excited about celebrating the release of the revised standards and measures, and we, of course, value our ongoing partnership to ensure tribal voices and opinions and feedback are included into that process. So thank you for joining us today. Any questions that we receive, I'll be sure to reach out to you about getting those answered.
Great, thank you.
Thank you. All right, so let's get our presentation going for our second half of the Institute. Okay. So now we're going to transition over to a more tribal applicable side of things. So we're going to be discussing assessing tribal public health capacity. And one of the ways that NIHB supports the assessment of tribal public health capacity is through our Public Health and Indian Country Capacity Scan. It's a long title, so we do call it PHICCS for short. So PHICCS is basically a national scan conducted every 3 years by NIHB in partnership with the CDC, and it's to assess the capacity of tribal health and tribal public health capacity organizations for delivering their public health services. So this is done in hopes of helping tribes as well as tribal organizations, partners, even policymakers better understand the dynamics of tribal public health infrastructure and assist them in planning for future improvement. So PHICCS can help tribes determine their current needs, their existing resources, as well as priorities for future investment. So the first PHICCS report was published in 2019. We are excited that we're now in the piloting phase for PHICCS 2. So in preparation for that, we're just making sure that all the instrument tools are revised and improved according to some of the feedback that was shared with us. And we're excited to get that underway and have everything launched sometime towards the end of the summer, hopefully. So I just want to note that I'll be referencing PHICCS data throughout today's presentation. So since it's basically just the most accurate source of data that we have relative to tribal public health capacity. So that's really what makes it unique, because it's the only national tribal specific public health capacity survey of its type for tribes. So it takes into consideration those unique things that make up tribal public health settings and the components that are not often included in other national surveys. So through the PHICCS report, we found out that tribal health organizations are most often the main provider of public health activities, but based on the data, you can look at the other organizations that provide some level of these services. So this really demonstrates the complexity of tribal public health infrastructure, as well as those networks surrounding capacity. And it also shows the fracture system, not necessarily a bad thing, but it points to the need for clear roles, responsibilities, some of those strong relationships that were described earlier through partnerships, and of course, respect for sovereignty. Okay, so when considering public health infrastructure and what capacity is needed to support those activities and what that looks like, we also want to think about public health authority, which was mentioned several times by you guys. So just thinking about who was over public health decision making. So public health authority is going to entail both governance, meaning who's responsible for public health matters as a part of the official mandate, as well as your public health laws, policies, and regulations. So PHICCS was able to demonstrate that tribal health organizations vary as the entity which provides oversight and direction for public health governance. And this speaks to the specific types of laws and policies that tribal health organizations reported, including who had authority over your policies, goals, priorities, as well as your public health regulations, public health codes, which came up today, as well as things such as taxes, fees, and levies. PHICCS also help identify organizational priorities related to tribal public health capacity and infrastructure. So some of the top responses included data and assessment, health education and health promotion, policy development, and planning. Okay, we also mentioned workforce earlier during our engagement segment. So considering what positions do you have, what additional positions are needed, what factors do you consider when choosing your staff, your education level, is your staff representative of the population or the community that you're serving, as well as other things like what training or onboarding do you offer for your staff to make sure that they're competent and prepared to provide those services. So all of that is a part of supporting capacity to get your work done and offering efficient services. And PHICCS was able to identify public health, behavioral health staff, as well as office and admin support and business and financial operations as being amongst the highest occupations reported. But even among those positions that are filled, you can still see that there are vacancies, which may reflect gaps in staffing. And even when looking at the bigger picture of what we're offering, it could reflect limited staffing, especially when we're considering burnout with how much we're contributing for workloads. That may be taken into consideration for having what staff is carrying out during their daily operations. And it may also highlight things such as behavioral health staff being a priority for integration in our system. So we're able to see some of those detailed data points within tribal public health systems. And then an important part of supporting the efficiency of services offered is through workforce development, which we brought up before as being a popular topic. So some of the common themes of workforce development needs shared during PHICCS included topics such as technical assistance and skills, certifications, hiring and licensing, assessment, accreditation, as well as assistance with technical assistance such as epidemiology. And then across 4 categories of public health needs, tribal health organizations identified through PHICCS finding that's the most frequently identified need. There we go. So this included not only funding support overall, but specifically tribally directed monies for improving public health in Indian country through either non-competitive grants from the CDC and other federal agencies to tribal set-asides from the CDC and other federal agencies that have funding reserved for states. Okay, so moving on to supporting tribal public health capacity, we're going to talk about one of our grant initiatives, which is called Strong Systems, Stronger Communities. So one of the ways that NIHB works in partnership to support public health capacity building is through Strong Systems, Stronger Communities. We call it SSSC for short. We have a lot of long titles, so we try to make it easy, but this is basically a program 5 years in cooperative agreement with the CDC that supports increased performance improvement practice, increased innovation in response to system integration changes, as well as progress towards national public health standards. And it's important that we note that this progress is promoted regardless of definitive pursuit of accreditation. So we often get requests from tribes that are just in the phase of learning about accreditation and maybe new to them. They may not even know about accreditation. There may be some that are in the mindset of they're not best fit for pursuing accreditation right now, or it may not be best for their community, or some may just not have an interest in pursuing accreditation at the time. But regardless, the information that is shared and the opportunities for improved performance capacity is still there regardless of the pursuit. So we are able to use those existing standards and measures that Jessica referred to as a guidance and kind of a set of standards that you can use on your own independently as a reference. So this program is accomplished through offering 2 cohorts. The first is our performance improvement and systems improvement cohort that allows awardees to complete a project that aligns with domains related to public health accreditation that they determine. So ultimately, it's up to the tribe to propose a program that's meeting the need for their community or their public health department. So we're able to support that through funding and other initiatives. And then we also have our self-assessment cohort that focuses on assessing overall public health capacity. So they learn about the ins and outs of accreditation. We really deep dive into each of the domains. We offer training to teach you about what they call the Big 7, which includes things such as your community health assessment or tribal health assessment, your strategic planning, what that looks like, performance management, your action plan. So it's really a more in-depth visual of what accreditation is, getting you acquainted with it. And even if it's something that you don't choose to pursue, you can still use those individual components to improve your efficiency of services. Okay. So to date, we have worked with over 20 tribes through the SSSC program on aspects of accreditation, in addition to providing technical assistance to others that reach out for assistance. So this includes facilitating learning communities. We have what we call Talk. It's kind of like our monthly meeting grounds where we get to discuss various public health topics. We have one-on-one technical assistance, promotion of peer learning and engagement. And this can include any topic that's a priority or of interest to a tribe or one of our awardees. And as a result of these initiatives, we've seen 90% of tribes make progress towards meeting the FAB standards and measures through their capacity improvement and performance improvement for the department. 79% have increased their resources related to public health improvement, and 68 have secured increased leadership support, which was also referenced today, just to support their public health improvement efforts and make progress towards those accreditation efforts. So to kind of close the circle on some of the information that was shared today, we have, excuse me, we have provided additional tools that tribes are using to build public health capacity. We have 2 of our former SSSC awardees who will be sharing some of their experiences and building on public health capacity support on their own. So at this time, I am going to stop sharing again. And we're going to turn it over to President Terry Parton from Wichita and affiliated tribes. And Wichita and affiliated tribes, they've actually participated in the SSSC program from both perspectives. So they originally joined completing a performance improvement, systems improvement project that they decided on, and then they came back as a repeat awardee and were able to actually conduct the assessments that kind of aligned them with the gaps that they have and the resources that they have, and they were able to use that to kind of determine their next steps and best practices. So at this time, President Parton, you should be able to share your screen. And you're also on mute, so we can't hear you. I'm sorry.
All right, can you see that?
Yes.
Okay, all right. Sheet of sheets, Terry Parton, Titty Kitty Kitties. So my name is Terry Parton, I'm Wichita, and I'm president for the Wichita affiliated tribes, and I am glad to be here today. Just telling you a little bit about our health programs and what we do at the Wichita affiliated tribes and how it has helped us throughout this. I wanted to give you a little bit about our vision and mission statement. Our vision is to continue to enhance the quality of life for the members of the Wichita affiliated tribes and for the Wichita tribal community for all future generations. And our mission is, the mission of the Wichita affiliated tribes is to defend and protect tribal sovereignty and to provide holistic, culturally based services that enhance the quality of life for our Wichita people. We will institute, embrace, and advocate for tribal and community unity, family support, health and mental wellness, which I'll talk about today, economic growth, education, and environmental protection to preserve our culture and the solidarity of our Wichita people. Our tribe is 3,674 tribal members. We are located in Southwest Oklahoma, mostly in Caddo County, but we also go into parts of Grady, Canadian, Blaine, Custer, and Washita counties. So just kind of tell you a little bit about our experience with NIHB. So we, as Jessica had mentioned, that we had first applied for the Performance Improvement and Systems Improvement Grant through NIHB. During that grant, we used a survey that went out to tribal members that just kind of surveyed the programs and stuff that we had and things that people would like to see. And then the second part was our self-assessment. And so we had already done a strategic plan with another consultant, and then we came back and some of the stuff that we have found in that strategic plan, we kind of emphasized in our questions to our tribal members in the performance improvement and systems improvement. And so with that, we've hired a health services administrator, and we have a SAMHSA administrator now. And so our health services sees over certain things, and then we have our SAMHSA administrator, which kind of tied into all the stuff that we were seeing with like suicide prevention and alcohol and substance abuse. So kind of tell you a little bit about our programs. We were a BIA 638 program, and we have as of February 1st of this year, we are now self-governance, and that covers our CHR and our EMS, public health, chemical dependency, mental health, and health education that we have contracted from IHS. And so, as we did our assessment and looking at things, and we wanted to pursue this self-governance so that we could take a step closer to being able to take care of our people. And so we did that. We also have our operations and maintenance. We contracted that out from IHS a long time ago. And so we have that program. Back in 2015, we started a tribal member health insurance plan. We were finding that we were offering full paid 100% insurance benefits to our staff at our tribal government and also our casino. But we still had tribal members that wouldn't use the health insurance, and a lot of it was they couldn't meet the copays. They might make $10 an hour and have full insurance, but they still could not meet the copay, so they weren't utilizing the insurance. So we implemented a tribal member health insurance plan, and this also does provide services to tribal members outside of Oklahoma. With IHS, we're limited to a 10-county service area, and so we weren't being able to health insurance to tribal members all over. And so we implemented this. They get $1,500 per year, or up to $1,500 per year. It could be all major medical, or they could use a certain amount for dental, vision, prescriptions. We also include medical marijuana in that now. And so they could use those for different things as long as they don't use more than $1,500. We also have the special diabetes program for Indians, SDPI. We have a tobacco grant, a cessation grant, where we partner with the Southern Plains Tribal Health Board. They have the main grant, and we have a sub award. We have a fitness center. We also have contracted with the state of Oklahoma and the Oklahoma Healthcare Authority for Money Follows the Person initiative. The Community Health Aid Program, CHAP grant. We are in the middle of that right now as a, I can't remember the name of it. Anyway, we're doing that grant right now. The dementia grant, we were finding that a lot of our tribal members are suffering from Alzheimer's. And so they had a state and a tribal grant. We went for the state grant, and we're able to get that grant. We just did that one because it came open sooner than the other. So we are working on that. We're doing a music memory. We were talking about culture earlier and tying in culture and stuff. We're doing a music memory using some of our language and stuff with that. Tribal management grant for the health board. So we have the IHS tribal management grant. Sorry, I have a misspelling in there. We are forming our health board. I'll talk about that a little bit in here in just a little bit. And then our master, we started, as we were talking about all of these things and start doing more, we ran out of space. And so we started master planning our complex, since we sit on 10 acres and there's 79 behind us. So we started master planning that, adding in a pharmacy, a wellness center, and a behavioral health center, and hopefully at some point being able to do some I can't even think of what I was going to say. Anyway, we started master planning that, and as we were master planning, all these grants became available. The EDA grant, it was supposed to have been $5 million, and they lowered it, but we pursued the pharmacy piece with that and have been awarded that grant. And so we're working with the EDA on that. And then of course we have lots of SAMHSA grants. So just kind of talking about the SAMHSA grants, we probably have probably about 7 or 8, I would say, SAMHSA grants that range from capacity building for substance and alcohol abuse and suicide, suicide prevention, and then some that deal directly with suicide and alcohol abuse. And they differ in age ranges. So some might be youth oriented and some might be geared toward older adults. And so we started pursuing those several years ago. And one of the things that we would like to do at some point is to have a treatment center in our area. You were talking about earlier about culture. What we find is we're sending a lot of people off to different places to get treatment, and then when they come back home, they're in the same environment, and the people that they're around aren't getting that, understand, you know, when they come back home that they can't be in the same environment that they were in and stuff. And so if we were at some point to be able to get a treatment center here in Anadarko, that would help bring the family in and also treat them. And you know, the alcohol and substance abuse and suicide, mental health and stuff all ties into every part of education. I mean, if you're having, you know, abusing alcohol, you start having all these other problems and stuff. And so it ties into everything. Our tribal management grant for our health board, just kind of going back to that, we had applied for the TMG grant a couple of years ago, and then decided that we wanted to get a helper. We're doing all this stuff, and in some of these cases we need some expertise to you know, to develop policy and everything. We can build buildings, we know how to do that, but to write the policy and understand those levels of making sure that we're doing the right thing when we offer services. We wanted to get a health board to oversee that. Right now we have 5 health board members. One is a pharmacist, and he also has owned businesses. He's one of our committee members. One is does a lot of research, works with one of our universities in Oklahoma, and then he's also worked on a lot of our SAMHSA grants. We have one that is a psychologist, and she also works with the Veterans Administration. And then we have one that's in social work and one that's a cardiologist. And so we kind of have a full range of people with doctorates and on our health board. And we're in the final versions of getting that set up, and so that they can start working on, you know, helping build our public health capacity to address all of these different issues that we're having and stuff. Our Money Follows the Person initiative, that one was done with the state of Oklahoma and CMS. Several years ago, we had a tribal member that came into my office, and she was needing help filling out papers. She had had a stroke once, and she was trying to get some assistance and stuff. And it took like 3 hours for us to fill those papers out in my office. And then we faxed them off, and a lot of it was just repeated stuff. And so the next morning she ended up in a nursing home. She had had another stroke. And so that specific grant is, you know, one that we really want to build the capacity on also, is because we have a lot of elders out there that, you know, they get stuck in that they can't fill out all the paperwork. And so they just put it aside and don't follow through with that. And so being able to get people out of nursing homes where they can stay at home and with their families and stuff is something that we really are trying to do. And then, you know, yeah, that's just kind of ties in everything that we're doing at the tribe. I think whenever we applied for that, the grant from NIHB, you know, that kind of opened our eyes to the needs of our tribal members. You know, dementia, that's really become prevalent here lately, that we've had a lot of tribal members that are suffering with that, and not just helping them, but also their family having, you know, to deal with that, and being able to give them resources to help them address those issues. And then, you know, we did the self-assessment where I kind of seeing, you know, all these gaps that we have. You know, people our tribal members in the first part was telling us what we weren't having. And then now when we look at ourselves and the departments and stuff, seeing that there's needs for other things. And so that's just kind of, where we are. We haven't started the whole process of accreditation. 1, we need space, and 2, we need to get the health board fully functioning so that they can help us move into those processes. You know, it'll probably be a long time before we get there, but you know, you got to start somewhere. So that's probably the biggest thing. This is just our committee members and stuff, and just want to thank you for allowing me to kind of speak about our tribe. I don't know if anybody has any questions.
Thank you, President Parton. And we do have one question from Camille Johnson in the chat. It says, do the health members consist of outsiders, or do they come from within the community or tribe?
Our health board members?
Yes, ma'am.
Okay. Gage, or he's the pharmacist, he is one of our committee members. There's three others that are tribal members. One, the one that's doing research and has worked with our SAMHSA grant, so he's kind of familiar with our grants and stuff. And then the cardiologist, he has some contracts with IHS. He's not even native. But one of the things that we found is we live in Anadarko, so a lot of times when people get the PRC, use the PRC, and they get contracted out to somewhere, they're having to drive almost an hour to go see a cardiologist, and he gets a lot of those. So if he had a place to come and meet down here, you know, once a month or once a week or whatever it may be, if he had a place where he could come down here, then those people would not have to go all the way to the city. And, you know, some of them don't have transportation and stuff like that. And so what we were thinking as we were, so we invited him to be on our health board, but also as we're trying to build infrastructure and stuff, that was one of the things we wanted to provide space, not just for that, but even like dental. If we don't have our dental contracted out from IHS, but at some point, if we were to do that, we would need a space for them, even if it's just, you know, once a month or something where we could service our people to get dental care.
Okay, thank you. Any additional questions? And you can also unmute your line as well if you would like to chat. Okay, not seeing any additional questions, just lots of thanks. And says, thank you for sharing. I love hearing about what you're doing for your people. Powerful. And you do a lot, very great array of services. Awesome. Okay. And one of the things that we wanted to highlight as well when we were trying to find which tribes would be like great contributors to the discussion of public health capacity is really reflecting on the reality that a lot of tribal public health departments are in different stages of public health capacity building, or even just public health in general. We've had tribes reach out to us that are just now in the process of developing boards, are in the process of building a public health department outside of their clinical services. So it was really important that we encompass some of the perspective of a tribal public health department that wasn't necessarily in the active steps of pursuing public health accreditation. And Wichita's was one of the tribes that was in SSSC that we really love working with. We saw a lot of great progress. And one of the components of public health capacity building is realizing we need to first figure out what we have, where we should be heading, and then realizing that a part of, even with the question that was asked earlier about equity, is being able to bring in different partners and members of the community to form kind of equitable conversations around some of these topics. So one of the things that we do as a part of the training for the self-assessment cohort that Wichita affiliated tribes participated in was showing them or training them on how to develop some of those partnerships and form their own groups or team members that would be that would participate in their assessment. So President Parton, we do want to thank you once again for participating in our discussion. We look forward to seeing the great progress that you guys are able to make. It's been a privilege for working with you through SSSC, and it's always a pleasure to have you come and share some of your expertise with other tribes as well. It's really valuable, and we love to see the production or the productive activity that comes from those activities. So thank you so much.
Thank you.
Okay. So next we're going to move over to Dr. April Cross from the Pasquayaki Tribe Health Services Division. Just make sure I can get my screen. Okay, there we go. Okay, Dr. Cross, I am ready when you are, and I can progress your slides for you.
All right, thanks. Good morning or afternoon, if it is afternoon for anyone. I'm presenting here for the Paskuyaki tribe. I'm their accreditation coordinator, and we were accredited in August of last year. And next slide. Let's see. And so I'll just tell you how we developed a lot of mostly documents during our accreditation process. And next slide. I can do the next slide. Thank you. So as the previous speaker mentioned, we too were pretty heavily oriented towards clinical services. And we have, a wellness center, we have Boys and Girls Club, we have specialists, we have a center, we have behavioral health, dental, we have a lot going on, and as well as providing health coverage for tribal members who don't have other health insurance. So we did discover that we were clinical, and we had to really turn our eyes towards more public health and documents. Next. And so this is how we saw our gaps and really went to work so we could more fully develop our health department. Next. Ooh, it's so small. Let me look at mine. And so I've made this it's kind of, anyone who's working with the standards and measures will know where we're coming from on all of this. So in the beginning, we started working on accreditation in 2012. And just in the beginning, we did have our beginning of quality improvement work that we started in 2010. And we had public health codes. And now we had an outdated EOP draft that kind of never got established the way it needed to. We had a small environmental health and accident prevention program with IHS as a strong partner. We have had a lot of data, but it was not centralized. And we needed more access to state databases and more agreements with the state and the county. And we do have always had a strong community health nurses and representatives program, and they've always done vaccinations and helped community members with various things. And they also do run a specialty clinic for specialists on top of our primary care providers who are contracted. We have a relationship with Pima County and have had several signed MOUs with them over the years. And our most recent one had been in 2016 with a full spectrum FRET MOU. And we do have lots of programs with WIC, special diabetes, transportation, and many others. Next. In our accomplishments as we've gone through things with the help of Standards 1.5 is that we have we made a performance management plan that is very heavily based on Native American principles, and that helped us more further establish our QI plans, and we got our strategic plan more robust. We updated our public health codes, added some new ones, and we detailed more clearly our public health authority. We ended up with a signed emergency operations plan. Is this my end? I'm nervous. Okay, good. We did end up with a very great EOP plan at the end of the pandemic, and part of what helped us get through is the EO plan that we had started. We have our completed CHNA and CHIPS with increased efforts to regularly receive, centralize, and update and analyze data, since there's lots of data in the CHIP and the CHA. We expanded our environmental and public health preparedness programs with the help of Indian Health Services. And we increased our public health oriented work done with the CHRs and CHNs, expanded our relationship with Pima County. And we are currently reforming our SDPI program. We've broken it up and just reworking it so we can even be more effective than we already were. And we've streamlined our public health messaging thanks to the branding that we established during accreditation. So that's a kind of a summary, and now I'll go into some of the more details. And we are a 638, this is a 638 tribe, which is quite helpful because we could make our own decisions. So in 2016, we had contacted an external consultant to help with our performance management plan, but it didn't work out. And so we have enough people here that, you know, we were able to wrap our heads around it and start a draft. And then we hired a tribal member who was able to really fill out a PMQI plan, and it was really good and really helped us with getting everything settled. And in 2017, we got the action strategy platform, which allows us to track our progress. So action strategy is a nice platform if anyone's looking for something to track their QI and strategic plan and anything else that they're doing. Next. And for our public health codes, we began to meet regularly in order to look at what codes the health department did have on board already. And we were able to revise them. And first and foremost, we affirmed that we are the public health authority here on the reservation and in the area. And with the help of the council, we revised the health codes to we revised our quarantine codes, which turned out to be incredibly helpful, and we never thought we would actually use them much. And then it was huge, as well as how we contact different individuals regarding infectious disease. At first, it was about things like syphilis, but then it turned into COVID. Also, we got some new codes for yard cleanup and tobacco use, to name a few. Next. In our emergency operations plan, like as I had said, we did have a draft, but it wasn't able to go anywhere ultimately. But with the draft, we revised that. So we had another draft, and that turned into our template for our COVID response for the whole tribe. So it was very helpful. So when we first submitted paperwork, our documents for accreditation, unfortunately, we did not have the EOP completed. So that turned out to be something we had to fix. But at least, you know, the draft was something, and it got us through COVID. And so during COVID, we made a COVID EOP, and then there started to be coordination among the whole tribe on how to respond to COVID. And we also contracted with a consultant who worked for FEMA, and he turned out to be the person that did our final drafting of the EOP, and he was very knowledgeable and helpful and responsive. He was fantastic. He's from Wise Oak Consulting. And then, of course, after that, we did our 2 AARs, our 2 tabletop exercises, all during COVID. And we're able to do after action reports on those and do a revision of the EOP again, just to fine tune it. Thanks to this EOP being done and finished and COVID, the tribe developed a new department, the Office of Emergency Management. And so that's become a very active department at the moment. And they are now working to increase our partnership and be named in the Pima County's EOP. Next. And for our data, data is always a big deal, and we've got lots of it, but we need to centralize it. And so we started a data committee, and that allowed us to review data sharing agreements with outside entities and partners and look at what kind of data we have, which includes a lot of clinical, lots and lots of clinical surveys, grant data collection, grant data that's in the reports for our grants, mosquito trapping from the county and other things. We went ahead and we had to really work more on MOUs and agreements with partners, including the state and the county, and agreed on what they could deliver us for our data. Like, we have our wants, but they had to tell us what they could give us. And that's a whole nother level of, how do they identify the tribe versus just a person who is Native American versus Yaqui. But we got those things together, agreed on what they would deliver and, how often, so that we don't have to ask them. Because as soon as you ask them for the data, FAB will say that that's not surveillance. So just FYI, don't ask for it or don't tell them you asked for it. We didn't have an epidemiologist before COVID, and I actually acted as an epidemiologist when we were first tracking COVID, but thankfully we now have one, and she's been great, and she also has an assistant. And that's helping pull data together as she starts to monitor it more. And as we start getting more, because during COVID, we didn't get much data from anybody because everyone was stretched beyond their capacity with COVID. We need to get an electronic health record that combines behavioral health, regular clinical, dental, and ideally pharmacy. And it's turning out to be a very big lift. It's quite difficult to find something that supports everything we need it to support. And then when it does, it's so expensive. So we're still working on that, but we're still centralizing data, at least in one location, if not in one EHR. And also, a big accomplishment is now we're on we can get onto our state databases, and we have really strong agreements for those. And most of the county data is in the state data. So we don't get into any county databases because all of theirs is already with the state. Next. And we have a really strong, a very robust community health nursing and representative program. We have over 60 employees in that area. And so what we did was we made a new an operational organizational chart. We found a nice example from Pennsylvania, one of their health departments, and we made it to where there's kind of public health and then clinical and then administrative, and just tried to delineate more of who was doing what, and just to try to get our definitions and goals, and even to help the nurses or the CHRs think more of they're doing public health. Because for them, they're just picking up people, they're taking them into appointments, they're doing med boxes, they're doing all kinds of amazing work, but there's not a definition behind it. So it's kind of interesting to nail that down more with kind of like the public health 101 kind of education. And I guess just a shout out to, the CHRs and CHNs were the biggest part of helping with COVID. Along with my clinic, we're the ones who started doing all the testing in the beginning. And I feel like all the work we did for accreditation helped us be ready for it again, and had our minds more in like collecting data right off the bat, which turned out to be incredibly helpful. And just the whole tribe worked on COVID, including enrollment, human resources, all of just social services. Everyone on the reservation helped with COVID. It was amazing, an amazing time. And Indian Health Services was amazing too. And so now the CHRs are getting to get back to their regular business, which has been exciting for them and a nice change. Next. So we are in Pima County, and we did have before COVID quarterly meetings with the county, and we went ahead and they understand our accreditation needs because they're accredited. And we were able to step it up and develop an IGA, an intergovernmental agreement with them rather than just an MOU for emergency activities, data sharing, workforce training, and epidemiology activities, and all the surge capacity that FAB wants you to document. And I have to think there's another tribe that's accredited that helped us finish one of our measures that had to do a surge capacity that we would have never gotten it done without them. So I thank them so much. Also, the state and the county they now do have tribal liaisons, and they're pretty strong, and we have good relationships with them, and it's helped get things done for accreditation and just on the ground, just getting information and communication done better than maybe it was done a decade ago or 5 years ago. And then accreditation also, it helped us strengthen our relationship with Indian Health Services, because the one thing we've kept with them even for 638 is the environmental services angle. And they are so public health. So they really helped us. They really helped us grow. And they do our inspections. They do lots and lots of training for us, mosquito trappings and more. And again, during COVID, they were absolutely amazing. And they were here in our health department helping us or trading us. If we ran out of test kits, they'd bring us more. And Just can't say enough for how much Indian Health Services helped us. Next slide. And then there's workforce. We did not have a workforce development plan before accreditation. And so in 2016, we contacted the University of Arizona's Western Region Public Health Training Center. And they helped us conduct the first employee assessment. And based on that one, we were able to offer trainings through them as well as other places. And we developed our workforce plan with that information. And we used Pima County's workforce plan as our template. And now in 2020, we got some funding from the Intertribal Council of Arizona, and we have done another assessment, and it's a bit different than the first assessment. So right now we're in the process of revising our workforce development plan and hoping it to get back on its feet now that COVID has calmed down. We'll start thinking about other things again. Next slide. So I feel like there's so much other stuff you could talk about. So I tried to just get it down to just documents. And so just the last slide I have here is just the plans and documents developed. What I didn't get here is just plain old policies. We wrote a lot of policies for including health equity for accreditation. And then you see here we have the performance management plan, the quality improvement plan, our workforce plan, community health assessment, community health improvement plan, a strategic plan, our operations plan, a public health emergency operations plan, our risk communications, continuity of operations, branding strategy, and lots of updates on health codes. It's a pretty big job and lots of documents. So I really, to appreciate FAB, I really love their revisions, and any chance to have lost documentation due is fantastic. And they did streamline a lot, and I really thank them for that. Last. And we just like to thank everyone who helped us along the way with funding in general and training, and especially with getting accredited. The one person that I didn't get on here is FAB. So of course, FAB was amazing. I probably asked Marita 1,000 questions. She answered every single one. She's amazing. Also, CDC has been very helpful to us. Robert Woods Johnson Foundation, Intertribal Council of Arizona, Red Star International, now known as 7 Directions, the National Indian Health Board, who we've had lots of projects with, and the Indian Health Services. And that's all. Thank you for listening. Let's see.
Right. Let's see. Let's stop sharing so we can see everyone who would like to engage. We're going to open the floor up for Q&A. And because it is the end of our session, you can direct your questions to either President Parton or Dr. Cross. We do have a few questions in the chat for you, Dr. Cross. Let me go back a little, make sure I'm not missing anyone. Okay, so our first question is from Lizzie Moore. She says, was there a difference for you between public health codes and policies? She also mentions that she can provide examples as well verbally if you would like her to elaborate more. So it's an easier question.
Okay, is Lizzie going to say more, or I'll just, if she wants to pipe in, she can. Yeah, our policies is very different from our public health code. So the code is definitely, the lawyers helped us with the code. The lawyers had to help mold it, make sure we were going in the right direction. There's still stuff that we were working on that's not done yet. And so code, a lot of the code, you have to know that you can work and partner with like the police department, the lawyers, or housing. So there's a lot involved in the codes and the writing of the codes, and making sure you're not stepping on the county's toes, or not really stepping on them, working well with them is important, because they have a lot of resources. And our policies are more of our internal policies, or else I would have to go to finance and ask them, hey, can you establish this policy, because it's not here yet. And there weren't as many lawyers involved in the policies.
Can
Can you provide an example of what a code might be and sort of like, because I guess my question is, we just opened our own public health department. So we're starting from the ground up. And so we're really thinking about infrastructure and where we should start. And so my question is like, as far as the codes, like who would you, the purpose for having a code is to enforce it, to make sure that it's being adhered to. And so if you were to create a code, for whom would you be telling, like, who would you be telling the code to and for what reason? Can you give an example?
Like the example I can think of is let's say it's like the sexually transmitted diseases. And so let's say syphilis, which is on the rise, and people like to ignore your notifications at times. And so on the policy side, you're writing a process of, we find out this person has syphilis and these are the actions we take to let them know and find out about their partners and do notifications. So it's like an internal policy and procedure and how we're going to address things after we get the syphilis diagnosis. And then on the code level, it's more like, let's say for the way we did it was, when someone especially if someone will not respond, or let's say they will not quarantine, or we can't get to them, we molded, we looked into law and legalities and molded something that gave us the right to pursue, to go to someone's house, or let's going into quarantine stuff to possibly, even if we have to get more law enforcement involved, help, let's say, quarantine someone that will not do it. I know we didn't do that. I'm just saying, I'm trying to phrase it well.
That's great. I just wanted a practical example. So that's great. Thank you so much.
Okay, thank you, Lizzie. So I think we'll alternate. So we had one question in the chat. We have one question on the floor from Erica. Erica, you're free to unmute your line whenever you're ready.
Hi, my name is Erica Meng. I work at a Klamath Tribal Health Facility in Klamath Tribes in Southern Oregon at a health facility. We also just opened up a public health department and are starting from the ground up as well. We're not on a reservation. And so my question is, with the public health code, we are currently, we do right now, COVID case investigations, contact tracing, all of that, but we're following Oregon Health Authority. My question is, should we be looking into creating our own public health code, but we're not on a reservation. So I don't know if we can just enforce what's currently at the state level, or should we be reforming it for our own?
I can't completely answer that, but I'd say definitely just have really try to have a great relationship with the person who does have jurisdiction. And since I don't know all the answers to that, because everything we've done is reservation based, and we really don't have. I mean, as I say, the Pasco Yaqui tribe doesn't have jurisdiction out in town, so that's where we had to really work closely with the county with our agreements versus on a reservation. So I don't know how it works for, let's say, a checkerboard reservation, or what the ins and outs of that are. But I think Cherokee would know well, and I'm not sure who else.
Great, thank you.
Okay, thank you, Erica. We have a follow-up question from Lizzie in the chat. She's asking, can you clarify whether accreditation is granted through the state with help available from NIHS, or through NIHS with help available from NIHS? A little confusing, Lizzie, sorry.
Well, as far as
I'm not, and I'm new, I'm an intern, I'm a grad student, so apologize if this is ignorant, but is public health accreditation that you just received, is that granted? Like, is it like having your own county? If a tribe is accredited, if their public health department is accredited, is that accreditation granted through the state, or is it granted through, who's the governing body of accreditation of a tribe?
Well, FAB is, they're out in Alexandria, Virginia. And so it's more of a national organization. It's voluntary to be accredited. So we're accredited through them. So, you know, the state and local health departments have nothing to do with it, but we have to show we have a relationship with them in order to be accredited. And they have to show that they have a relationship with tribes to be accredited, and you know, hopefully the new standards and measures makes that proof a little stronger and vigorous for the states and counties. So it does, you know, it's not anything about, I don't know how to say it. It's not like a joint commission accreditation. It's different, and it's I feel like what it does is help us kind of level up and say, hey, we met these requirements too, and helps make us more equal partners, and lends us a lot of legitimacy.
Great, thank you so much.
And I see one hand from Nina on the line.
Yeah, can you hear me? Okay.
We can.
Awesome. Sorry, I'm in a crowded room. I just wanted to follow up to Dr. Krause's comment that, as she mentioned, this accreditation is through the Public Health Accreditation Board. So it is separate, and it is for public health accreditation, and it's the same set of standards and measures for states, local health departments, and tribes. So as Dr. Krause mentioned, it's kind of everybody can participate who chooses to, and is kind of, you know, has met the same set of standards with various differences, again, to recognize that tribes may run their public health departments differently, and so they have to show different levels of engagement in states and locals for, you know, data sharing perhaps that fits the model of tribal data sovereignty. And it is different than accreditation that, you know, the ambulatory care clinic or health system would receive, like AAA, HMC, or the Joint Commission.
Yeah, definitely. And that's what is, you know, it is great, and it's just awful that, you know, we have the same standards and measures. So if you want to be like, Fab, why are you doing this to us? All they'll say is, you don't have to do it. You don't have to do it. So it's an adventure. It took us 9 years, but we did it. I see, let's see, let me see. Okay. I see one thing. I don't know how to save a chat thing. So maybe, or hopefully this will be something I get. This one, there's a direct message to me, but I'll ask you about that afterwards. Let's see.
Worries. And we have a link from Erica. She's just providing the tribal departments that have received accreditation status through FAB, in case you want to visit that. And then we also have a question on the floor from Brandon. Brandon, you're free to unmute your line whenever you're ready.
Hello, and thank you. This is really an interesting chat. I do have a question that you referred to during your presentation. You mentioned that you're a 625 tribe, I believe. Can you clarify what that means?
Well, it's a 638. I'll do best.
Excuse me.
Yeah, I'll do best I can. I'm probably going to leave out something, but it just, like, there's some tribes that were set up with Indian Health Services, and so Indian Health Services, that, you know, they're kind of in charge. So, and so what 638 allows for, you can take certain shares out of different areas and keep certain agreements with IHS, and you make your decisions. But so once you're at the kind of like the highest level of being 638, then Indian Health Services no longer they don't approve your plans anymore. You approve them yourself with funding from Indian Health Services. And that's a compact, and it's renewed. I think it's every 4 years or so, but there are negotiations for budgets, but ultimately the tribe's in charge of their decisions instead of having to pass them through Indian Health Services.
So my question then is that's exclusive. I'm sorry. My follow-up question then would be, that's exclusive to your area then, or state, correct?
This is the United States. So,
okay.
You know, yeah. So, you know, Indian Health Services was the primary health providers, and you know, for a lot of different things, environmental health, many years ago, and over time it's evolved to where tribes are able to take more control of their own business. Yeah, and here Nina put up a link so you can learn more about the 638 compact and contracting.
Thank you, Nina. Okay. Does anyone have any additional questions or comments before we wrap up for the afternoon? Let's see. Okay, so Chris just has a simple question about the slides, and they will be available on the session page for this afternoon. So we'll be sure to get everything uploaded for you. Okay.
I guess I'll put my email up here if anyone has any questions. Let's see, I gotta share it to everyone. There we go.
Thank you, April. Okay, so I'm not seeing any additional questions or hands raised. So I want to again thank President Parton, Dr. Cross, and Jessica for being here and sharing such important information with us all today. If anyone has any additional questions for our presenters, you can ask them in the chat box, which you can find on the session page and the online conference agenda. And that will be following the end of the session, and we'll be sure to make sure you get a response to them. Please remember to fill out the session evaluation at the bottom of the session page. The slides for today's presentation and handouts and recordings for the session will be available on the page shortly after. Please join us for the next round of sessions, which will begin shortly at 3 p.m. Eastern. Please also be sure to visit our virtual exhibitors page in Marketplace. This week we have an exciting conference exhibitor game. So attendees who visit with our exhibitors will be eligible for entry into a raffle for prizes, and there will be 4 tiers. So 1, visit the booth using the Talk Now feature. You'll be eligible to win $250 on a Visa gift card. If you utilize the Talk Now feature with at least 12 booths, we will be able to receive 1 of 4 $100 Visa gift cards. And then on the 3rd tier, we have, if you start a chat with at least 18 exhibitors, you'll receive 1 of 4 $50 Visa gift cards. And the 4th tier is leaving a calling card for at least 18 exhibitors. You'll be eligible to receive 1 of 6 $25 Visa gift cards. So please note that you can only be eligible to receive 1 prize. We want to make it fair for everyone. So if you qualify for prizes in multiple tiers, we will award you the higher prize amount. And we'll redraw for the remaining prize. So once again, thank you for attending our Institute for today, and please enjoy the rest of the conference. Thank you.